Good afternoon, everyone. We are now live.
Good afternoon, and welcome to this meeting of the Health Policy Commission's Advisory Council. I'm David Seltz, Executive Director of the Health Policy Commission. I'm pleased to welcome everyone here for this meeting, this final meeting of the Advisory Council on this December meeting, this snowy day. I'm really excited to welcome all of you here for what I think will be a really enlightening conversation and engaging conversation. I'm really pleased to have so many of the Advisory Council members here with us today. And I'm also really pleased to have the chair of the HPC, Deb DeVoe, with us today. Good afternoon, Deb. Thank you so much for being here.
Thank you. My pleasure.
So as this is our final meeting of the 2-year session of this particular Advisory Council, we wanted to, as often is the case at the end of the year, do a little bit of reflection over the last 2 years and a little bit of looking forward. So for today's meeting, we're going to spend a little bit of time reflecting on what we've talked about over the last 2 years, a little bit of reflection on the cost trends hearing that just took place last month, and spend the bulk of our time having some discussion about the future priorities of this council, future priorities for the HPC, and future priorities for the work and of the healthcare system ahead. First, on the first slide here, just a reminder of all of the esteemed members of our advisory council. Today, I do know that we have a number of designees for some of our advisory council members. I do encourage you to please speak up during the discussion. And when you do, just please introduce yourself as a designee of your organization. As I mentioned, this is the final meeting of this 2-year advisory council session. And so we will be reappointing the advisory council for the next 2-year term. And to give a little bit more information about how that will work, I'm just going to turn it over to our Deputy Executive Director, Colleen Elstermeyer.
Thank you so much, David. Yes, it's that time of year, not the holidays, but time for you all to ask to be reappointed to the HPC Advisory Council. We really recognize the significant commitment of time and expertise that you all make as members of the Advisory Council. We're so grateful to you for supporting our mission and our goals. The next term, as David said, it'll be 2 years. It'll run from 2025 to 2026. The calendar is not published yet, but we do plan to hold 4 90-minute meetings each year, in addition to working with you all outside of those meetings. So just really appreciate the amount of time and commitment you make to this. If you are interested in being reappointed and serving for another 2-year term, please email Ashley Conter, the HPC's Deputy Chief of Staff, to record your interest in serving for the next term. And we're looking for those by Friday, December 20th. We're going to drop Ashley's email into the chat, and you'll be hearing from her as well to remind you. We're going to consider all returning members and new additions as well, as we do every term, and we'll be rolling out the membership in the new year. And of course, on behalf of the HPC, thank you all. It's invaluable what you do for us. So we're really appreciative, and we hope you want to return. Thanks. Back to you, David.
Great. And to echo Colleen's thoughts, it really is truly valuable what you provide to the HPC, to provide to our staff, to provide to the work of the HPC, both in these meetings and outside of these meetings, to be able to connect us to resources, to connect us to experts within your organizations, to be able to be people that we just call on to provide us advice and counsel. It really is just such a privilege and an honor to have the connection with all of you. So I hope you do consider reaching out to Ashley and asking to be reappointed. Moving on into today's meeting, as I said, first just wanted to spend a little bit of time reflecting on what we've been talking about in these meetings over the last 2 years. So I actually went back and looked at our agenda topics over the meetings starting in January 2023 through to today. We've had 6 meetings of this advisory council over this time period. and was just going back and looking through what were the agenda topics that we talked about over this time period. And I think one of the real strengths of this advisory council is that, we can be really, kind of flexible and timely about what are the topics that we bring to this discussion group every time that we meet. And it provides an opportunity for us to be reflective of, what are the dynamics that are happening in our system right now? What are the most timely topics that we think are most important to be able to engage in and to discuss in real time? And so we always kind of adjust our agendas and our topics, to really reflect what people, want to talk about and what we think is most important. And so I thought it was really interesting to kind of go backwards and with the benefit of hindsight to see, what were the topics that we talked about over these last 2 years, and did these actually feel like the right issues, with that benefit of hindsight. And, looking through these topics and what were the things that we had spent the time in these 90 minutes with, as I look through these lists of topics, it does feel like these were the things that were the most important topics over these last 2 years. And the challenges facing our healthcare workforce, the capacity constraints, the impacts of some of the market closures, affordability challenges, pharmaceutical costs. These really were some of the main challenges, facing our healthcare system over these last 2 years. And this venue was really the place where we were talking about these issues. One of my questions for you all is going to be, what are the topics that you think that we should be focusing on for the next 2 years? And that's going to be, really our main topic of conversation today. So wanted to take this moment to really reflect on what we have been talking about as we start to think about where we should prioritize moving forward. To help with that, ground that conversation, I first wanted to spend a little bit of time reflecting on the recent cost trends hearings that the HPC just held. I'm grateful that many of you were witnesses at the cost trends hearing, and I know many of you either attended or maybe watched online. And I know many of you watching this meeting online also probably watched the cost trends hearing. I thought it was a really successful hearing. It was full of just incredible testimony and content, and I personally felt really energized coming out of that meeting, even though some of the problems and challenges that it surfaced felt daunting at times. So I know that we circulated to all of you a summary and a recap of the cost trends hearing. That recap of the cost trends hearing is also posted on our website. Also on our website, we do have a full recording of the cost trends hearing. Also on the website, we have a summary of the pre-file testimony and a lot of other materials for the public and for members. So, but I do want to hear from you all about your reflections and takeaways from the hearing, especially as that helps inform really where we go next. So I'm just going to spend just a few minutes just highlighting a few of a recap from the hearing, and then I'm going to open it up to hear from all of you, especially those of you who were either there or were witnesses, to hear from you about what you thought was most important coming out of that hearing. And then we'll have a larger conversation about future priorities for action. So next slide. So the theme of the hearing this year was from crisis to stability, the path to a more affordable, accessible, and equitable healthcare system. And we really grounded the hearing this year in the wake of the considerable harm of the bankruptcy of the Steward Healthcare system and other market disruptions. And we had a really incredible group of panelists, community leaders, policymakers, healthcare industry representatives, all really focused on the substantial toll that bankruptcy and those disruptions have had on our providers, our communities, our healthcare workers, and also reflecting some of the larger systemic challenges facing our healthcare system right now, and how those are reflecting out onto the residents of the Commonwealth. We started the day with some great testimony and remarks from our Attorney General and from the Governor. You know, the Attorney General provided some really inspiring remarks, I thought. She outlined some of her priorities for the upcoming legislative session and highlighted her support for increased oversight and accountability of certain market participants, and indicated her support for enhanced authority to protect Massachusetts consumers. She also highlighted, and I encourage all of you and the public to look at her most recent cost trends report, which had a number of findings around medical debt, which found that there was an increasing rate of medical debt for Massachusetts residents, particularly Black, low-income, and female residents. And she is calling for legislation to protect Massachusetts residents who are facing unaffordable medical bills. We also heard from the Governor, who also was focusing on what happens next in the wake of the Steward bankruptcy. And I thought her remarks also really stressed an importance about making investments in primary care. She stressed the importance of investing in primary care and called for equitable reimbursements to all primary care providers. She stressed that the United States spends half of what other developed countries spend on primary care. She really emphasized the important work that community health centers do in providing critical access to primary care. And she called for equitable reimbursements for these safety net providers. I think it's important to note that she also closed by saying that this is not business as usual, and she really challenged all of us to think about bold and innovative action moving forward. Next slide. Our first panel of the day included the new operators of the Steward Hospitals and the Physician Network. And these leaders really reflected on some of the new opportunities to provide local, integrated, high-quality care in these hospitals and physician networks for their communities, but also really acknowledge some of the challenges coming into these organizations and the need to build trust both with the communities and with their workers. They reflected the need to re-examine some of the underlying reimbursement models that were there, and I think acknowledge some of the moral injury that happens with Steward Healthcare, especially with the workers in these institutions. I would also note that in the case of Revere Medical, which is the new physician network, Benson Sloan, the CEO there, reaffirmed commitments to transparency and to engagement with the Health Policy Commission and with the state, as they are a new private equity-backed organization new to Massachusetts. Next slide, please. On the panel number 2, we heard from community leaders who really highlighted that the Steward Healthcare crisis really exacerbated existing inequities in our healthcare system. And the panelists highlighted that the worker burnout resulted in people feeling both overworked, underpaid, and under-resourced, and that there was a real opportunity for investment and revitalization of healthcare resource planning, and a need for greater communication, collaboration across the Commonwealth to address some of these underlying systemic issues. The community health centers included on this panel really highlighted that there was a dramatic rise in acuity and volume that was requiring greater time capacity, and greater resources to care for patients, but that they were paid at lower rates than other providers, and that there was really short-term and long-term consequences of the closure of some of these institutions, and a need to really think about new solutions on strengthening our critical healthcare workforce. Next slide. Our third panel included CEOs of two of our major health systems and two of our major health plans. And here, the panelists talked about some policy solutions, and there was a real consensus around, again, a need to invest in primary care and the need to move care out of the hospital setting and to invest in community-based care. And some of the panelists, particularly the payers, talked about the need to strengthen the benchmark and to have more accountability on affordability. The health plans also talked about some of their challenges with provider price requests and the affordability challenges that is having on their members. Well, some of the health providers talked about ongoing workforce shortages, inflationary headwinds, and increasingly complex patient needs. And finally, on the last panel of the day, we had leaders from a number of our major associations who were really focusing on talking about what are some of the policy solutions where we could find some consensus to move forward. There was a lot of discussion around the need for greater transparency and accountability of both private equity involvement in our healthcare system, as well as greater transparency and accountability of the pharmaceutical sector and pharmacy benefit managers, PBMs. There was a great deal of conversation around investing in primary care, as well as, I think, a good deal of consensus around the need for greater state health planning and understanding the supply and distribution of our healthcare services. Some of the panelists talked about the need for a greater investment in or attention paid to affordability. And overall, this panel also talked about the need to work together on solutions. And I think to wrap all of this up, I think one of my final takeaways from the hearing was that there was, I think, a great deal of conversation about some of the real systemic challenges that our system is facing right now, and that there is a need and I think a desire for a revisiting of a collaboration, of a communication, of a willingness to work together that this system found during the pandemic, where people were really willing to work together to put aside, in some cases, organizational self-interest to the benefit of a broader social good. And how could we rediscover that spirit because that these challenges were so great, and that there needed to be the sense of urgency to work together to find solutions, because the current path was unsustainable. And so while, I think, as I said at the beginning, there was a sense of daunting challenges, at the end of the day, I think I left feeling a sense of an opportunity, if we could capture that spirit of working together to identify and work together to implement and take action on solutions. And so as we move into the next part of our conversation later today around where do we move forward, I really hope to hear from you all about how do we do that? what are those areas that you think are most promising that we can actually make progress on? What role the HPC can help play in supporting that, and how we all, HPC and this advisory council, can work together to move forward and make real progress. So those are some of my reflections and a little bit of a very rapid recap of some of the main themes of the cost trends hearing. At this stage, I'm going to pull down the slides, and I'd really love to hear from you all, especially those who were witnesses or those who were watching in the room that day, about what were some of your key takeaways, what were some of the things that most resonated with you as you watched this cost trends hearing. What did you hear? What did I miss that in my quick recap? And would love to just continue to expound on what came out of this this important day. So I'll open it up and would love to hear from all of you. Chris?
Well, first of all, it's great to see everyone, and I thought the hearings were terrific. I credit you and Deb with the tone being so much better than years gone by, and I do think you set forth the spirit of collaboration, which I think is the only way we're going to get anything done. And if there's probably the only one thing I think that was great during COVID was how we all worked together for the good of the patients. And I just have two things that I think we could tackle that actually I think everyone is kind of on board with. And one is, what can we do to eliminate the administrative burden that both the insurers and the providers have, which is somewhat onerous for all of us, and really maybe how the HPC could help. I was thinking is maybe some kind of a task force or something, where we can sit around and talk about that. And I think everyone is all in on trying to eliminate unnecessary work. And I don't think that hurts anyone. I think it helps everyone. So I think that's one that's would be a good place to start. The other is labor. If there's one thing, having been in this industry for a long time, that we continue to struggle with on the cost side, and I try to bring our messages from the HPC back to many meetings that I'm in, but labor continues to be the biggest driver of costs in organizations like actually almost anywhere in healthcare. And so, is there a way we can talk about, I can bring some ideas to the table, like we have developed some make your own programs. So we, have hired a lot of nurse educators, and we, train our own ICU nurses, OR nurses. And techs in certain areas. Is there a way we can use that sort of a model and try to put it across more organizations to try to reduce the cost of labor in healthcare? Can we work with the state in some way I know that workforce they've already done some things around workforce, but creating some programs that would help to bring more people into the field. I know we're working closely with the Girl Scouts to try to introduce young women to different parts of the healthcare field, so that we can start very early with trying to grease the skids for that pipeline. So those are two things I think that aren't hard, in the sense that I think we could maybe get some, results quickly. I think it's something everyone could get behind, and maybe would help us to sort of advance what our mission is here, and that's to try to lower the cost of delivering care in the Commonwealth. And you've probably noticed across the country, we're one of the last regions to bounce back post-COVID. And there's just so many reasons why, because of the high cost of everything here. But I do think the time is right for us to all work together. And maybe if we got some of these groups together and tried to start talking about some substantive things that, 6 months from now, we'd be highlighting all the great work that we've done.
Yeah, thank you, Chris, and I appreciate both of those topical areas, and I also appreciate and would love to hear from others about, like the how of it, like, you know, should it be a task force, on what type of timeline? Let's set goals, like in 6 months, what can we do? On, I think we need to be a little bit more, this is me speaking now, a little bit more aggressive in saying, let's not just, you know, say let's work on this over the next 2 years. Like, let's work on this in the next 3 to 5 months, and pick specific topics and bring the right people together. And so, would love to just continue to hear from all of you about, what are those areas? Who are the right people to bring together? What does that look like? What can we achieve? What does success look like? And so, thank you. I appreciate those comments. Laura?
Oh, thank you. David, thank you for the opportunity to participate at the cost hearings. I thought it was a great conversation. And I think we all do need to work together. I think we have serious challenges in our state. I think we heard from both the health plans and the hospitals that some are having really great difficulty and financial difficulty. So that's something we need to pay attention to if we hope to continue to have a premier healthcare system in our state. But I think overarching for me, and for the folks we serve, is affordability. That continues to be a huge challenge. You see that in your data. I would say one observation at the outset, and whatever we do, I think we need to have a set of facts that we all agree to. I was a little surprised during the hearing that I heard some testimony under oath that didn't seem consistent with data and facts as I understood them. And I think you actually took an opportunity to correct some of that. And so I think it's important that we all have agreement around a set of facts, that, data and principles that we're agreeing to moving forward. There are things around administrative simplification that we should all be looking at, whether we go to automation for prior authorization. That's something we're very interested in engaging the providers with. I think we also want to look at things that I think are achievable in the short term, like surprise billing, site neutral payments, facility fees. You've done a lot of research about low value care. And so I think that those things put burdens on patients, and I think that we want to address that with the provider community. I think we'd be happy to engage in a work group, an informal work group. Another area is primary care. We've been spending a lot of time with legislators and policymakers around primary care. I think we need the hospitals at the table to figure out how we're going to invest in primary care, and do that within the cost benchmark. This can't be cost additive. And then I think we need to measure it, because I think there isn't a ton of data about how investing in primary care, or quantifiable data, will add value and save costs, but I just feel like it will. And so we need to measure that. And will investing in primary care keep people healthier and out of emergency rooms? I think it will, and I think that will incent people to do it. But I think we need to be sitting with the providers to figure out the best way to do this. It's complicated with contracts. But if they're committed to this as well, and committed to doing it within the benchmark, I think that's really important. Statewide planning, I heard a lot of agreement around that. I think that's something we can all get behind. But I think what we could be facing from the federal government in the future, the not too distant future, is very serious. So I think we can't get our heads around cost containment soon enough, because I think we're going to be expected to do more with a lot less. And so I think this is a conversation that we all need to engage in together in a collaborative spirit. So.
Thank you, Laura. I agree. And just maybe to play back some of the things you said, that you'd be open to working on primary care, some of the admin simplification, prior auth automation, statewide planning.
Yeah. Yes.
Thank you. I'm going to go Jake and then Carleen.
Thanks, David. And I echo Laura and Chris's comments and commending your team for the hearing. My comment, yeah, you covered it a little bit just now in the discussion in one of the panels in transitioning care into the community, and certainly encouraged by that. I think my comment is oftentimes I feel, or we feel, that those conversations really aim toward hospital at home and kind of continue to overlook home health and home care. And I think in the pre-filed testimony from the payers, there was really a lack of discussion around home and community-based services. And so I think in the context of cost containment, right, continuing to push forward the value proposition for home health and home care services, and trying to get the payers to see that value. And of course, a lot of that is on our industry and our providers to present that value proposition. But I think HPC has an opportunity here to include that in the conversation.
Thank you, Jake. You may have seen in some of the slides that I presented at the cost trends hearing, highlighting some of the workforce challenges in some of these fields. And, there was some discussion about, some of the patient throughput challenges and moving people out of the hospital, and how some of that really is a reflection of the need for, some of the challenges in the home health field, home care services space, maybe a need for more investment in that space. So I think it is all part of a continuum, and we need to think of it as all part of a continuum. So I appreciate that.
Yeah, thank you.
Erica?
Thanks, David. I think one of the areas that keeps showing up in the data, and also in the payer pre-filed testimony, is the driving trend of pharmaceutical spending. And I don't think the state has come up with a really great policy solution around that. And the HPC did a great report on GLP-1s, which looked at data through 2023, but we've really just seen trends continue to explode since then. And so I would ask the HPC to continue examining that issue, but also other high-cost drugs. Cell and gene therapy is one that we sort of see coming down the pike that we're really concerned about. And having the HPC sort of have the data, but then bring people together to think through what are real policy solutions that the state can do. I think oftentimes people throw up their hands and say, oh, that's at the federal level, we can't do anything about drug costs. But other states have taken action on pharmaceutical prices. And there are other ideas that maybe we haven't thought of, like a high-cost drug pool or bulk purchasing or something. What are the ideas that this state could actually do to address pharmaceutical costs? Because right now, it's just being sort of put on the backs of employers, and they're having to make those tough decisions on whether or not they cover these really important drugs for their employees. And that's, I don't think, a place where we want to be. We would love to have some type of policy solutions in the state that allow us to have the broadest access, but also have a way to pay for it.
Thank you, Erica. And certainly when we look at the data, this is clearly one of the biggest drivers that we're seeing. I have saved in the agenda kind of my own topic agenda for like, what should we be focused on in the future? And so I was kind of holding this time for a little bit more of like reflections on the cost trends hearing. So if we want to move to that part of the conversation, I'm happy to just kind of jump there. But Don, I saw that you had your hand up.
Well, maybe I can serve as a bridge.
Perfect.
The equity and access issues being discussed at the cost trends hearing, and the recognition that reforms and investment in primary care are essential to addressing that. I would simply add that the integration of behavioral health and primary care is a critical part of the solution. And in fact, I mean, it's come up at different points in time, but whether that goes back to Governor Baker's Health Reform 2.0 or Senator Friedman's bill for 30% and 30% investments, people have recognized this in a number of different ways, that these investments need to go hand in hand, because the real outcomes in terms of better access, an improved equity picture, and reduced cost and improved quality come from that integration. And the data are there. The evidence-based practice of collaborative care, and other models that integrate that care. So, and I'd be happy to work on that in any way. The other part I would raise, and someone mentioned, and Laura mentioned, needing to look forward at cost impacts. I'm very concerned with what's ahead, what's threatened ahead, that medical debt is going to increase. And that problem has two dimensions. It has the patient dimension, but it also has an impact on the providers who are going to be called upon to care for people, increasingly possibly in an emergency context, if they don't have adequate coverage. And the debt hits them and the debt hits the patient, because they may send a bill to the patient that creates debt for the patient, but they may not get paid, as you know, if the patient can't afford it. So and I think it's something we need to be thinking about going forward.
Absolutely. Let's come back on the primary care and BH piece.
Yeah.
Matt.
Thanks, David. And thanks to the team again. You did an excellent job with the cost trends hearings. I like to be there in person to the degree that I can. Was able to do that again this year. Look, I think so. My reflections will be a little more global, high level. Hope they're still helpful and relevant to folks. From where I sit, we're in a new phase of this affordability challenge, and it's happening at clearly a very difficult time for many, but not all, in the provider community. And I've been spending a fair amount of time as a reference going back to the CHIA Hospital Financial Report. And I think that paints a very compelling picture, which we should spend more time sort of understanding the details of. But I think high level, the one that struck me was that we, in 1 year, increased net patient service revenue, which payers like the GIC, those are our dollars, increased by $3 billion in 1 year. And when that happens at the GIC, that is hundreds of millions of dollars in additional dollars to deliver essentially the same product. So in my mind, that is the sign of a really fundamental problem with our system. And look, many in the healthcare provider market and others are clearly struggling, and we need to be aware of that and mindful of that. But I think as you and I think others referenced during the hearing and elsewhere, you have to remember the context. The dysfunction that this problem presents a struggle for many others as well outside of the healthcare system. So yes, the healthcare system is struggling in some areas. Welcome to the party, right? I represent public sector workers on, for the most part, modest paychecks, retirees on fixed pensions, also quite modest. We rely on the state budget. So when we have a status quo offering of plans to our members, and we draw several $100 million from the state budget, that's unsustainable, right? Just to use the phrase that everyone keeps using. But it means that we can't invest those dollars in a whole host of other things that we all think are critical and important inside and outside of healthcare. The rising burden of prescription drug prices, Erica mentioned GLP-1s. For us, we're spending hundreds of millions of dollars on those drugs now. The rise in provider prices that we're seeing in the marketplace is frightening, frankly, and I hope it's temporary. But I go back to what some of the governor's message was, and the quote that you had on the slide for her earlier that called for bold action, and you called for bold action. And that's what it's going to take. If we're going to continue to nibble around the edges of the affordability challenge, we're not going to get anywhere. So my hope is that we see policy solutions, that policymakers will pay very close attention to the policy recommendations that the HPC has put out and act on them. Because if they don't, payers like the GIC and others, and I know there's representatives of the business community on here that are in the same boat, will be faced with very real negative and impactful choices that are going to affect real people's lives. So we're in a new phase, as I started off. We're in a new phase, and I think we have to acknowledge that. This is not the same continuing problem. Many of the dynamics continue to be the same as they have been for as long as I've been in this business. But everything's just ratcheted up several notches, and we're going to have to think big. We can get everybody around the table. We can work in a collaborative fashion. But if we're not doing big things, we're in for some hard times. And I hate to leave it on that note. And I hope that's not a bridge to somebody else. Well, I hope it's a bridge to somebody else expressing a more optimistic and hopeful future.
Well, thank you, Matt. And well, I think consistent with what the governor said, that these are big challenges, and big challenges require bold and innovative action. Ron, would love to hear from you.
So I think, the Policy Commission has repeatedly done a good job of pointing out the problems and the fact that primary care and mental health are areas that we need to improve access. But the problem is a time constant. So I'll give you the analogy of a patient that's hemorrhaging, and you're told that you can get a transfusion in another day. And in order to save that patient, you really have to stop the bleeding. So when we're looking at primary care and mental health, we're looking at 4 to 7 years of training for whatever type of provider you want to call. And that means that in that 7-year period, a 4 to 7 year period, you have to have other solutions. So we have to really look at, one solution might be reentry of providers who've decided to retire because of the adverse effects of administrative burden, et cetera. That I think was maybe 25, 30 years ago, there was a nursing shortage, and there were many nurses who had left the workforce to have their kids and raise their families. But when the salaries went up, a number of them came back into practice for another 15 or 20 years to save the profession in our workforce. So I think that one solution would be to get the 4 medical schools to collaborate. We train more residents than any other state, but we don't retain them. So one of the possibilities would be collaboration between the schools to try to come up with a program to try to keep people here, because if people train at multiple levels in a given area, they tend to stay there. So that's one possibility. But also reentry, the barriers to reentry mean that sometimes you have to take tests or courses and so on to do that. But that's an immediate bump up in numbers that could help us. And I think that, sure, if we can, again, say that we have this problem, but the 6 or 7 year period is going to be a period where the system fails. So we have to have enough immediate solutions and band-aids to help keep it going. And I don't really hear those solutions coming forward.
Thank you, Ron. I was struck by, and I think encouraged by the governor's strong statements around primary care, and her call for action on primary care and investment in primary care. And that was echoed throughout the day at the cost trends hearings. So I'm encouraged and interested to see what will be coming out of the administration, whether that's going to be in the budget or in the next legislative session, in terms of their priorities there. And so I think there is going to be an opportunity in the short term to really make some progress there. And I think we're hopeful to be a part of that conversation as well.
But I would be encouraged to look at the impact of giving proposals to see what can help us more immediately and so forth. So I think that's a major part of solving this problem.
And I would also note, Michael Curry, has suggested at the cost trends hearing, one other idea around restoring the GME add-on in the Medicaid program. and maybe targeting that specifically for primary care residency. JD?
Thanks, David. So just three kind of areas of comments. First is I agree with Matt, what Matt was saying earlier. And I actually think you, David, through this group, is uniquely qualified to convene some folks and come up with these big ideas. I mean, this is really a great group, and you have a you have a bullhorn and credibility, I think, that can do some really good things with the folks on this screen and those who aren't. So I just want to echo what Matt said and raise my hand on behalf of the roundtable to be part of that. Second, it looks like you were taking notes on volunteers on certain topics. The roundtable is particularly interested in the workforce issue that Chris brought up at the beginning. Would love to work on that. If there's, if you're thinking about forming task forces, statewide planning, we're actually involved through the Blue Cross Blue Shield Foundation, which is doing some work there, and would love to engage with you on that as well. And we are starting to hear more at the roundtable on the primary care issue as well. Those would be three where I would volunteer the roundtable's services and resources to help. And then finally, there are a few lenses that we're using at the roundtable that cross industry that might be applicable here as you think about what's next. One has come up, which is the vulnerabilities that we may have due to the change in federal administration. And as we look at some of the industries that are foundational to the Massachusetts economy, it's healthcare, higher education, clean energy, life sciences. I mean, a lot of these industries are vulnerable right now, and there's a little bit of uncertainty what's going to happen. But I think that is worth thinking about for this group, is how do we protect ourselves against some of those vulnerabilities, assuming they happen. And then the second one is the acceleration of AI, which is happening everywhere, of course, and impacting this industry like it's impacting many others. And just thinking about what those impacts could look like, particularly around the conversation of cost and quality. So just a couple of thoughts stuff that's happening at the roundtable that may or may not apply here, but definitely want to raise my hand on behalf of our organization to engage in some of those other issues.
That's great, JD. And actually that's a perfect segue to bring back up the slides and maybe pivot into, I think, a continuation of this conversation. Which was really where I wanted to go next, which was to really reflect back some of these big topical areas that I heard at the cost trends hearing, that we have been reflecting on as staff and commissioners at the HPC. Some of these big topical areas that have been calling out for some more dedicated attention, perhaps some kind of dedicated working groups, some dedicated project plans to really roll up our sleeves and work in, and as you said, JD, perhaps looking for some volunteers to work with us on. So on the slide, I've put up, there's 10 big topics here, and one of my questions is, what am I missing? And are there more things that should be on here? And JD, you just mentioned two that aren't on here. One is around thinking about kind of protecting and strengthening our position as a state leader, given the change in administration, and also kind of the future in technology changes and AI. I think those are two really interesting things that we should also be thinking about. But here you can see, 10 topics, and many of these we've already touched on today. And these are big topics, right? Promoting affordability, strengthening primary care, and I think given Donna's comments earlier, I should probably say, and integrating behavioral healthcare, health planning, strengthening market oversight, workforce challenges. You can read through these on your own. So would love to, as you're reviewing this slide, would love to again open this up to see your reactions to some of these topics. Are there ones that resonate with you? Are there others that you think should be added to this list? And are there ones that you are really interested in and working with us on as we move forward into next year? Lizette?
Lizette, you're on mute.
Okay, can you hear me now?
Yes.
So these topics are interrelated, so it's hard to pick one.
Yes.
But, you know, when you talk about primary care, strengthening primary care, I think it encompasses quite a bit of the topics. But I would like to talk about not only strengthening, but making primary care interventions more effective or efficient. And I think community health workers are key in that regard. And I think I would like to put the spotlight on standardizing community health workers' interventions within primary care. The role of community health workers, clear intervention protocols. Everyone in the team understands what's appropriate and not appropriate to refer to community health workers. And within that standardization, also the possibility of expanding the role of community health workers to fulfill some of the shortages, and also creating pipelines for community health workers who know the community, who are smart, savvy, and experienced, for them to explore careers in areas for which we have shortages. We are doing very successfully training some community health workers to get their masters in counseling psychology, but this is a small dent. If we could look at how to really scale these possible tracks for workforce development using community health workers to alleviate some of these shortages, that will be fantastic.
That's wonderful, and we would love to follow up with you on that. We're really thinking about this primary care space and how we can help contribute some ideas here, and so I'd love to follow up with you on that. Thank you. Carlene?
Great. Hi.
Hi.
Thanks so much. It's nice to see everybody. So a couple of thoughts. First, I want to endorse the idea that this list may need to have either some flexibility or an added item to respond to what is going to get thrown at us federally, that we just we have guesses and none of them are happy guesses. And so we're going to have to be flexible and so maybe there should just be an item like taking it as it comes, as it's thrown at, something like that. Yeah. The other thing I just wanted to lean into a little bit is the health equity, the advancing health equity item that you have on here. David, I'm thrilled, of course, that you have that there. And I think it's important to have that as a standalone item. I think it is also essential that the charter or whatever, the discussion topic, the groups that are assembled to talk about any or all of the topics that we talk about include health equity. So, right, yes. It's both a standalone thing so that it gets appropriate attention, and it needs to be woven into all of these topics. We are going to make no progress, or we are going to make unhelpful progress vis-a-vis health equity if it isn't stated, named, addressed in each of those groups. And that includes, you mentioned earlier, David, you want benchmarks. Those benchmarks have to include race and ethnicity and income, like stratification by those demographics so that we're certain that any progress that is made is not at the expense of people of color and low-income communities. So it just, yeah, want to really call us to action on that.
Thank you. I'm so glad you said that, and it's always one of a struggle because you want to put it in everywhere, and you want to also give it its own highlight. And one of our mottos and standards that we hold ourselves to at the HPC is an equity in everything approach. And so that is underlying all of this, and I'm glad you called that out, and thank you. Matt?
Yeah, just second everything that Carlene just said about the advancing health equity item. And I think my comment really is similar in nature about its corresponding item on the left. Not surprising, I suspect, promoting affordability. There's so much, there's so much that's underneath that as there is under advancing health equity. And what you have here is a combination of high-level priority areas for discussion mixed with some others that are a little more targeted, and I think that's right. If I were to rewrite your slide for you at your invitation, I would say promoting affordability could be more accurately described and still capture what we're after, which is addressing the known dysfunctions of our market that can improve affordability, right? And this is where we are, and I say this all the time, we're so blessed in Massachusetts to have the resources of the HBC and CHIA. We have how many? 13 years now, David, of insight that is data grounded from an independent state agency. We're one of the few countries, or one of the states in the country that has the best insights about where our problems lie in all of these domains. And, when it comes to promoting affordability, I don't think we need to do a whole lot more research. I think we know where we need to focus our attention, that we have known dysfunction in the market. It's consistent, persistent for a long time, and we need to address it. I'll just stop there. Thanks.
Thanks, Matt. Well, if it was a perfect slide, it wouldn't create as much opportunity for dialogue. So that's really what I'm going for here. Chris, I see you with your hand.
Sorry, I can't find the hand button.
It's okay. I got you.
Thanks for seeing mine. So I guess this is a great list. And what I'll say is we've known this for a long time, all of these things. And it's like trying to boil the ocean if we try to tackle them all at once. And, I think sometimes we know all the problems. I think we need to pick two at the most. And let's make some task force. Let's, I'm committed to working on any and all of these from the hospital perspective. And let's, we know all the problems. I think we all need to focus on finding solutions. And I really feel that in the meeting today that everyone's ready to, jump in and have some thoughtful dialogue about this. So maybe trying to find a way of seeing where we can get the biggest bang for our buck, or maybe trying to bite off something that, maybe like the administrative complexity. For as long as I've been a CEO, like 24 years, that's been on the list, not here, but everywhere. So maybe that's something, and I know Laura is equally as interested, in doing that. So maybe that's a place to start. And primary care, because the governor clearly has an interest in that. So, maybe we can start to focus on, using the great data that you guys produce to help direct us to where we might get the biggest bang for our buck. And maybe the next year, in addition to sort of keeping up with the general things we talk about in the meeting, really, sort of hunkering down on two projects and committing to work on those. Just my humble opinion.
No, I really appreciate that. And that this is part of why I wanted to have this conversation is how do we prioritize? I mean, this is a list of 10 big things, right? And so how do we decide what to really focus our efforts on? And you started by mentioning administrative complexity and labor as two areas that you had recommended. I think workforce and primary care, are interconnected, certainly, and primary care and administrative complexity are interconnected in so much as part of our primary care challenge is around a burnout issue of administrative burden. So, there are interrelationships between all of these topics, certainly. Dr. Callahan?
Yeah, you stole my thunder.
Wow.
Being a primary care provider, I always get nervous when I hear strengthening primary care. I don't know what that means to many people, and I'm not sure that it covers all of the issues that make it a problem right now. With primary care, it's not so much that it's weak; it's we're challenged to do sort of schizophrenic things, right? We are talking about making people more healthy so that they're not as sick, so they don't have to utilize the services because they're well. Yet we're being told to see more patients because that's paying the bills. So we're somewhat saying, well, we're trying to keep them out of the system such that because they're well, but yet we're saying, no, we need them to come in, get them sick so they can come in. And why do we have a workforce challenge? It's because of burnout. So, you brought that up. And what I don't see in this list and what I don't hear a whole lot of talking is really figuring out what is it that's intrinsically in this market, which I hate to use the word, that makes burnout sort of requisite. It starts in medical school. It starts in the training of providers, which is traumatic and abusive. So it's you have a system here where it's hard for me to sit down and go to a Girl Scout troop and encourage them to become a doctor. Yes, come and join my trauma. So there's some things that we need to do, I think, that address strengthening the primary care provider instead of a system of trying to strengthen a system, because and I'm not sure how it would be done in terms of looking at these sort of bigger picture issues. These are bigger picture issues. But when it comes down to it, there is the patient and there's the provider, whether they be a doctor, whether they be a community. I love the idea of really strengthening and building community health workers, because if you have that within your communities, you can address some things that will keep them maybe out of the hospital. Okay. But this has always been and advancing health equity, of course, is involved in all. I don't know how we would do that as an advisory board. I don't know how you introduce a lot of this thing into policy when it's sort of we're given a scaffold or a structure, which I think is not designed to do what it is we're trying to make it do when it comes to the healthcare industry. And I'll leave it at that because I could go on, but we don't have time.
Well, very thoughtful. Thank you. Juan and then Laura.
Hi, good afternoon. Thank you, David. I think we'd be remiss, since we're talking about future priority areas, if we don't talk about what happens starting in post-January 20th. And particularly on advancing health equity, where the whole industry has a lot to be concerned about, but particularly in advancing health equity, the top three things that top of mind for me is, in no particular order, are immigration policies, right? And what happens to patients seeking care if they're concerned about being deported, if they have a family member who's concerned about the same. What happens to our employees who, we have a large constituent of immigrant workers across Beth Israeli Health, and they may have family members with mixed immigration status, the trauma they're going to be under. So that's one. Second one is obviously what happens to Medicaid subsidized services. I think it was mentioned earlier, the likely increase in medical debt, uncompensated care pools, that Medicaid goes to a block grant. And obviously, without overreacting and over speculating here, we know that those programs are at risk. What happens to the 1115 waiver and it gets renegotiated, and the large progress that's been made around health equity there. And then gender affirming and reproductive services, obviously, whether it's more people coming to Massachusetts or federal dollars that are at risk because of gender affirming services we provide here in Massachusetts. So anyway, I just flagged those top three. There's so much more, but just thinking of from a health equity standpoint.
Thank you. Thank you for flagging them. And my mind goes to the so much more, and it's sobering to think through. But thank you for flagging those. Laura.
Thank you, David. And Juan, I really appreciated your comments, and I do think those are the challenges after January 20th that we're going to be facing front and center here in Massachusetts. And I think that is why it's really imperative that we really begin to embrace this affordability agenda. And part of that is efficiency. Chris mentioned my name when she talked about administrative complexity. We're willing to have those conversations as part of a larger affordability conversation, because there are things that both the providers and the payers can do to make the system more affordable. And I think it's in our interest to do that sooner rather than later, given the fact that we may have many less resources in the future. As for primary care, I do think we need to get around a table and figure this out. It's very complex with contracting. Most of the primary care practices are now either owned or contracted through hospital systems. And so it's very complex. If we want to pay primary care more, we need to do that within the contract setting, I believe. And so we really need, if the hospitals are on board with this, we really need their assent to be able to do this in contracting. And it's going to take time. And I think the doctor really laid out some of the challenges for primary care. But I think one of the key things we want to do is be able to pay primary care more, but do it within the benchmark. So that means we're going to have some savings in some other part of the system. But I think this affordability challenge for consumers is imperative, and we just can't keep on passing out the cost. I think the entire system needs to become more efficient, particularly as we face the challenges that we could likely be facing after January.
Thank you, Laura. And again, on the primary care piece, I would just say, again, that the governor, with her remarks and her leadership here, I think is challenging all of us to get around that table and to work through these issues, and to have to seize this opportunity. And she really created a window here for us to take and to move this forward. And so I really hope that we can seize that and work with the administration. And I'm sure they have a lot of great ideas that they're working on, but her remarks were quite strong on this topic. And I hope that we can all really embrace the statements that she made. Is there anyone else who hasn't shared any thoughts that would like to?
Hi, this is Karina here. And, continuing on the theme of, affordability and transparency, I think we just need to continue to make sure that, the patients who are intended to benefit from discounts, do get those discounts. And, there's policies other states have looked at, such as sharing the savings. So, requiring plans and PBMs to pass a certain percentage of rebates to the consumer at the pharmacy counter. And then, there's been more action at the state level around the 340B program, which is a, federal program. And there are states, looking to even further expand the program in a way which wasn't originally intended. So I think, a report just came out of Minnesota about a week or so ago, where the Department of Health did a study around the 340B program, and some of the findings were the excess revenues that were providers were receiving. So I know our state legislature has been looking at 340B policy. But I think before the state acts in this area, there needs to be some type of transparency, or there needs to be some study of, where is the money going? What is it being used for? Are the right patients benefiting from the program? So, I cover the 50 states. So this issue of 340B is really kind of bubbling up in the states, and I urge the HPC to take a role in helping to really develop that transparency to show the full picture. Thank you.
Thank you. Thank you for weighing in. Well, I want to thank all the advisory council members for this conversation and for this dialogue. As we move into the next year and into the next term, I'm really open to hearing from you all, also about the how we move forward, about the how we work together, about the how we advance these solutions. These are 90-minute meetings with close to 30 different perspectives. And sometimes, it's going to require maybe a different format for us to be able to really roll up our sleeves. And so I really welcome your thoughts about the best way to do that. And so please reach out to myself, Colleen Elstemeyer, Ashley Conter, and about your ideas about how we can best do this. It's been a real privilege and an honor, of course, to work with you over these past 2 years. I really hope to continue to be able to work with you in the next advisory council session. And as was mentioned earlier, please reach out to us if you want to continue to serve in this position. And I really hope you all have a wonderful holiday season. Colleen and Deb, any final words that you'd like to share with this group?
No, nothing from us. Deb had to leave a little bit early today, so I think we're good. We're ready to close out. Thanks for all the comments in the chat too.